Hello, and welcome back to CE Solutions. My name is Caleb Frady. I'm a full-time EMS educator and a part-time paramedic here in North Carolina. Today's lesson, we're going to be learning more about the essentials of neonatal resuscitation, and this is Volume 1. The objectives for today's lesson are as follows. First, explain the transition from intrauterine to extrauterine life. Second, describe the initial interventions to perform after birth. Third, apply the pediatric assessment algorithm and ABGAR score to neonatal care. And lastly, describe newborn airway management and CPR techniques. The circulation of blood flow to a fetus and how it achieves oxygenation is quite different than that of a newborn or an adult. And what has to happen is after birth, there's a transitional period where the newborn begins spontaneous ventilation and starts to begin mature physiological circulation that mimics that of an adult. Now, oxygenation for a fetus is achieved through the placenta, and the blood flow largely bypasses the lungs to a point that they don't really participate in gas exchange. They're actually filled with fluid during a pregnancy or when a fetus is inside the womb. It's not until after birth that the fetus becomes a newborn and begins spontaneous ventilations when the lungs fill with air and start to participate in respiration or the exchange of oxygen and CO2 to resume or to begin normal physiological circulation and respiration. It's important for us to understand the transition from intrauterine to extrauterine life. And to be able to understand that, we first need to discuss how the fetus receives its blood supply and oxygenation from the mother. And that's achieved via the placenta. So the placenta handles delivering oxygen-rich blood and nutrients to the fetus. And there's some special shunts that exist that bypass the lungs. So the lungs during pregnancy of a fetus are not involved in gas exchange. They're actually fluid filled and somewhat collapsed. And then immediately after birth, when the newborn begins spontaneous ventilations, this is what allows the newborn to transition into mature physiological circulation. So while the fetus is inside the womb, there's three main blood flow shunts that allow this redirection of blood flow to occur. The first one is the ductus venosus, and this allows oxygen-rich blood to bypass the liver, and it carries it directly to the inferior vena cava and into the heart from there. So at the same time this oxygenated blood is being diverted into the inferior vena cava, there's also deoxygenated blood coming back to the inferior and superior vena cava. It's interesting to note that this blood actually doesn't touch because the shape of the ductus venosus causes that oxygenated blood to flow towards what we are going to talk about next, which is the foramen oval. And then the deoxygenated blood from the superior and inferior vena cava they mix together and flow into the right ventricle. Moving next into the foramen oval. So the foramen oval serves as a right to left shunt, which allows oxygenated blood from the placenta to pass directly into the left atrium and thus into the left ventricle to be distributed throughout the fetus's body. So this is what allows the fetus to directly receive its oxygenated blood from the organ of gas exchange, the placenta, just like an adult would from the lungs. Right? We receive our oxygenated blood from the lungs. A fetus, the lungs are filled with fluid, so it receives its oxygenated blood directly from the placenta, and that's achieved through the foramen oval. The third shunt for us to discuss is the ductus arteriosus. Fetal peripheral vascular resistance is pretty high, and this allows about 90% of blood to bypass pulmonary circulation and enter into central circulation, so the aorta, through the ductus arteriosus. So that's its main job, is to divert blood kind of away from the pulmonary circulation and into the aorta, because remember, it's already received the oxygenated blood from the placenta, so only 10% of that blood is moving through the pulmonary circulation to help those tissues grow and mature up until after birth. The ductus arteriosus is also responsible for regulating and diverting deoxygenated blood towards the placenta through the umbilical artery. So the umbilical vein is the blood vessel that delivers the oxygenated blood to the heart, and the umbilical artery is the vessel that delivers deoxygenated blood back to the placenta, and that's achieved through the ductus arteriosus, rediverting that blood flow. The transitional period occurs as a fetus transitions to a newborn. A newborn is the term that we utilize for immediately after birth, and then neonate is the term for 0 to 30 days. So for a newborn to successfully transition, really two factors have to occur. One, fluid in the lungs gets replaced with air, so the baby begins to take its first few spontaneous breaths. So the movement of air with those breaths into the lungs causes pulmonary vasodilation. That decreases the vascular resistance inside the pulmonary blood flow or the pulmonary circulation, and it causes the ductus arteriosus to actually reverse directions. So instead of it being a right to left shunt, it reverses and becomes a left to right shunt, and that allows the left ventricle to start to contribute to pulmonary circulation. So you begin to have respiration occurring in the lungs now, where blood flow is coming in, oxygen's making its way into the alveoli, oxygen and carbon dioxide are exchanging places, and the baby starts to breathe spontaneously on its own as that transition away from the placental lifeline that it has been utilizing for 40 weeks. The second factor that influences this transitional period is umbilical cord clamping. So when the umbilical cord is clamped, blood flow through the ductus venosus and foramen ovale decreases. This allows for more preload for the left ventricle, because all of the blood coming back into the right side of the heart is moving its way through the lungs, and the left side of the heart has more preload and allows the left ventricle to take over more of the cardiac output for the newborn and deliver blood through all the tissues in the body. Now, most of the time in full-term infants, this transition occurs smoothly. So a full-term infant is anywhere between 38 and 40 weeks. So what are some of the specific changes that occurs with the shunts from fetal to newborn circulation? So the ductus venosus becomes ineffective with cord clamping. It closes fully in about 2 weeks for full-term neonates. It can be delayed in preterm or newborns. The foramen ovale, so the increase in the left atrial preload as a result of lung expansion and decreased vascular resistance basically just renders the foramen ovale obsolete, right? There's no need for that shunt to bring blood from the right side of the heart into the left side of the heart, because now there's plenty of blood coming back into the left side of the heart from the lungs. So it's just obsolete at that point. The ductus arteriosus, like we talked about, switches from right to left, switches to left to right shunt, and that's what actually promotes closure of the ductus arteriosus and allows for increased oxygenation. It ends up later in life, it changes to what's called the ligamentum arteriosum, which is just a anatomy term for what it turns into. In full term newborns, this transition can occur quite smoothly. In fact, most live births, this transition occurs quite smoothly. In preterm infants or newborns that may have pre-existing conditions identified during pregnancy, they're at risk for a less than smooth transition due to several factors, such as underdeveloped lungs causing not as much of a peripheral vascular decline, allowing blood to move through the lungs finally. Maybe they have a less developed left ventricle, so the left ventricle is just not able immediately after birth to take over pumping blood throughout the body. The increased vascular resistance makes it harder for the left ventricle to do that also because it's pumping against more pressure or more resistance. And the fetal shunts in preterm newborns, they tend to stay open longer, and that can just affect that baby's ability to transition to extrauterine life smoothly. And that may be where, when we come along in the births that we attend to in the field, that can help explain why some babies may take longer to fully transition and may need resuscitation by us, such as ventilations, even CPR, and those other sorts of interventions that we'll discuss throughout this lesson. A full term pregnancy is 38 to 40 weeks, and anything before 37 weeks is considered preterm. So in 2024, Hamilton, Martin, and Osterman looked into what percentage of births occurred before 37 weeks, and they found that 10.41% of births were considered preterm. And then further, another report, Cash et al. From 2021, they found that in 2018, so what they did was they went to NIMSIS, the National EMS data bank, and they found that in 2018 there was 3,489 out of hospital deliveries. That represents about 3% of total EMS calls for that year. So 3% of total EMS calls, that's pretty rare for deliveries to occur in the field. But what's interesting though is 43% of the live births for pre-hospital providers in 2018 were considered preterm. So my take from that is that if we're going to deliver a baby in the field, there's a pretty good chance it's a preterm delivery. And with preterm deliveries, as we just discussed, the fetal transition can take longer. And that means that we may need to intervene with resuscitative measures more often in field deliveries than full term deliveries in the hospital or the field, respectively. So, with that information in mind, this really helps segue us into the next portion of our lesson where we start to discuss the assessment and management with an understanding that if we do deliver a baby in the field, there's about a 43% chance that it's preterm delivery and may need some sort of neonatal resuscitation. When preparing for a delivery and preparing the interventions to perform on a neonate immediately after delivery, the first step is to utilize that time prior to delivery to assess and prepare for any complications. So this would include your OB assessment, asking the mother about her age, length of pregnancy, any known complications with the current or previous pregnancies, asking about the frequency and intensity of contractions, fetal movement, any ruptured membranes or bloody show. Bloody show is a blood tinged mucus plug that is expelled as the cervix begins to dilate in the first stages of labor. Multiple babies or multiple gestations, any prenatal care, and any other relevant questions that are part of that OB assessment, assessing for potential complications. As you're doing this, you want to go ahead and start gathering all the equipment that you're going to need, not only for the delivery itself, but also resuscitation of the newborn. So, at a minimum, for resuscitation of the newborn, this is going to include warm and dry blankets, a bulb syringe, small clamps, scissors or a scalpel to cut the umbilical cord, and your resuscitation equipment, such as a bag valve mask to handle any type of neonate resuscitation you need to perform after delivery. It's also going to be helpful to pre-identify a resuscitation zone. This is going to be an area that if the baby does need immediate interventions after birth, you're going to take that newborn to provide care. The foot of the stretcher works really well for this. You can set the foot of the stretcher up with clean and warm blankets, prepare that area with the neonate equipment, and utilize that area for initial stabilization assessment and continued resuscitation. After you have delivered the baby and you've confirmed, airway patency and performed other neonatal interventions that we'll discuss throughout this lesson,
it is acceptable to go ahead and give the newborn to the mother and promote skin to skin contact and feeding if the mother's choosing to breastfeed. We're only going to suction a newborn's airway when necessary. So routine suction is no longer recommended. We're only going to utilize the bulb syringe if we identify obstructions inside the newborn's airway, then we would suction. After delivery, before and clamping the umbilical cord, it's important to keep the newborn at the level of the mother and keep the head slightly lower than the body. Part of your initial newborn care immediately after delivery, again before clamping the umbilical cord, is to dry, warm, and stimulate the newborn, as that's often what is required to facilitate the transition from intrauterine to extrauterine life. And lastly, perform a primary assessment. Note the time of delivery, assess airway, breathing, and circulation. Pay attention to the respiratory rate and effort, the infant's muscle tone, and their pulse rate. When feeling for a pulse, you can feel for a pulse at the base of the umbilical cord, or you can also find a brachial pulse in the newborn. Regarding cord clamping, delayed cord clamping is shown to be associated with lower odds of mortality in preterm infants, and the most current recommendations allow for cord clamping to be delayed until after the baby is dried, warmed, assessed for breathing tone, activity, and placed on the mother's chest. Generally, that can take about 30 seconds. So, ideally, cord clamping will not occur before 30 seconds unless there is immediate resuscitative measures that need to be taken, i.e., a baby that doesn't respond to dry, warm, and stimulation and needs BVM ventilations or CPR. Those would be cases where you would need to immediately clamp and cut the cord and take that newborn to your resuscitation zone to provide that more advanced basic level life support. The benefits of delayed cord clamping include a higher hematocrit level and better iron levels in the newborn after delivery. And then something you should never do is never should attempt to milk the umbilical cord in an effort to get more blood into the infant. That would actually be more harmful than anything.
Next, we're going to talk about the APCAR score, how and when to apply it. The APCAR score is initially used to determine the need for neonatal resuscitation, and then it's later used to determine the effectiveness of neonatal resuscitation. So we would assess an APCAR score at 1 minute post delivery, and then again at 5 minutes, and compare the two scores, and that helps us trend in an upward or a downward direction based off the interventions we have been performing on the newborn. Now, it's important to understand with the APCAR score that this should not delay any type of interventions that need to be performed. And it can occur as an ongoing part of our assessment, especially when you have more than one provider assisting you with this resuscitation. One provider can perform an APCAR score, while the other providers continue to perform interventions such as a bag valve mask ventilations and chest compressions. An APCAR score above 7 at 1 minute is considered reassuring, and that's further considered reassuring with progression from an APCAR score of 7 to 10 at 1 and then 5 minutes. A score of 10 is a perfect score according to the APCAR score, and a score of 0 is the lowest score you can receive. So I'll pull an image up on the screen here of a newborn baby, and we'll assess the APCAR score here to determine how to apply it in the field. Now, when we look at the APCAR score, it's broken down into 5 categories: appearance, pulse, grimace, activity, and respirations. And each one of these categories is assigned a number from 0 to 2, whereas 2 is being the highest score you can receive, and 0 being the lowest score you can receive for each individual category. So if we look at the image on the screen here, the first thing we will start with is appearance. You can clearly see that this is a vigorous newborn that has a pink trunk and pink extremities. So we would give 2 points for this newborn. Moving down to pulse, if we were to assess a brachial pulse on this newborn, we would find that it's 125 beats per minute. So again, we would assign a score of 2. Moving into grimace. So grimace is going to be the newborn's activity or response to external stimulus. So as we continue with our initial newborn steps of drying, warming, and stimulating, the newborn pay attention to the activity that you get in response to that stimulus. So in this newborn, you can see that the provider is drying off the top of the head, and the baby is crying very vigorously as a result of that stimulus. So we would again assign a score of 2. For activity, to assess activity, what we should do is we should grab both legs of the newborn just above the knees and gently attempt to straighten the legs. And as you do that, feel for how strong the newborn resist your attempt to extend both of their legs. Newborns that have resist extension and it feels strong would receive 2 points. If the newborn feels weak and maybe is delayed at resisting that extension, 1 point, and then if there's floppy arms and legs and just no response, that would be 0 points. With extension, the reason we assess this in this manner is when the baby is inside the mother's uterus, it's curled up into a nice, comfy, cozy ball, and then all of a sudden, the baby gets pushed out of that comfort zone and is open up to the big wide world and just doesn't want to stretch its legs, right? Wants to curl back up into a ball. So that is why the activity for the APGAR score is a reliable indicator for the progression and the need for intervention. And lastly, assess respirations. Now, in a newborn, we're not going to be able to count for a minute and get a true respiratory rate number as we might on an adult patient. It's more so about the vigor of the newborn's cry. So in the image here on the screen, again, you can see that this newborn is crying vigorously, likely very loud. So we would assign 2 points for this newborn. And then depending on if it was a weak cry or no cry at all, we would assign either 1 point or no points. So the newborn here on our screen has an APGAR score of 10. So post-delivery, an APGAR score of 10. We are super excited about that and everything is good. But not every newborn has a score of 10 right out of the mother's womb. Like I said, a score of 7 is considered reassuring. Anything less than 7 is a indicator for some level of neonatal resuscitation. The neonatal resuscitation algorithm may be the most important piece of information from this lesson because it's our step-by-step guide and a way for us to keep it simple when managing a high acuity, low frequency patient such as a newborn baby. When we look at the algorithm here, it's really broken up into seconds and minutes. The first 30 seconds after delivery, we should take the newborn, place it right onto the mother's tummy, just where the uterus is sitting, begin to dry, warm, and stimulate, hoping that that stimulation as we warm the newborn is going to allow us to get a vigorous cry and trend us in a positive direction. A couple other helpful points during this first 30 seconds is it's important to put the baby on the mother's tummy at that point because the mom is going to receive benefit from that as well, seeing her newborn baby, kind of seeing that process of the transition occur in real time. Something also to keep in mind with the climate in the ambulance or your environment, if you're able to control that, is while you're delivering the baby, so during labor, turn the air conditioner up all the way because the mother's going to be very hot, working very hard to deliver the baby. As soon as the baby is delivered, cut the heat up all the way because the newborn is going to be really susceptible to cold environments. So that's why it's important to keep them warm, stimulate them, dry them off. And after the first 30 seconds, if we have a vigorous cry, position the airway. If there's any secretions noted, clear them and give the baby to the mother and perform cord clamping after 30 seconds. So, as we talked about, should be no cord clamping occurring before 30 seconds. Now, 30 seconds comes and goes, and we don't necessarily have a vigorous cry where we feel comfortable go ahead and giving the newborn to the mother. At that point, it is appropriate to go ahead and clamp and cut the umbilical cord, take the baby to your resuscitation zone, and begin to assess a little bit further according to our assessment algorithm. When the first thing we would assess after that point is for any sort of breathing at all. Is the baby apneic and not breathing, or agonal respirations, or is there some sort of labored breathing with persistent cyanosis? So maybe you note that the skin is a bluish gray color and the baby has a weak respiratory rate. You should also assess a pulse at this 30-second mark because that also guides your decision as to whether or not we're going to provide back valve mask ventilations or provide supplemental and ongoing stimulation to the newborn. So we'll start with the heart rate being above 100 and the newborn has labored breathing. This would bring us to the right side of our algorithm where we would position and clear the airway of any secretions if noted. Begin to apply some monitoring devices if you have the equipment, such as a pulse ox. Regarding pulse ox, down at the bottom right of the algorithm, you'll see a chart that says targeted preductal SpO2 after birth. So immediately after birth, your neonate is not going to have a 100% oxygen concentration. And in actuality, beginning ventilations with 100% oxygen concentration has actually been shown to be harmful for newborns. So we should target these specific numbers. And if we're within those ranges, then supplemental oxygen is not necessary. But going back to the algorithm, we've determined that with the SpO2 monitor, the newborn babies is hypoxic at 1 minute after birth, so below 60% SpO2, and we would at that point provide blow by oxygen, which we'll discuss later in the presentation. I've marked out any type of ALS interventions, so the black lines you see on your screen are for ALS providers, which we will talk about in volume 2. Now, as you're performing those interventions, continue monitoring, continue stimulating, and assessing the heart rate and for any improvement in the newborn. This would also be when we would go ahead and assess our AVCAR score. So either we're assessing the AVCAR score while the mother is holding the baby or in our resuscitation zone while providing ongoing care. When we come to the 30-second mark back on the other side and we note the baby is apneic and has a heart rate below 100, that is an indicator for positive pressure ventilations. So we need to position the airway and grab an infant bag valve mask and begin to apply BVM ventilations. As we move down the algorithm from there, we're assessing the heart rate, and our target number is a heart rate above 100. If the heart rate falls below 100, we should either start or continue positive pressure ventilations, check for equal chest movement, and correct any ventilation issues we may encounter. So, are we having issues with a mask seal due to some sort of developmental abnormality like Down syndrome that's making it difficult for us to get quality ventilations on the newborn? If at any point the heart rate drops below 60, this is an indicator for BLS providers to begin chest compressions and positive pressure ventilations. It's important that we coordinate our positive pressure ventilations with our chest compressions, and we'll review that skill again later in the lesson. It's also important for BLS providers to ensure that you have the appropriate resources heading towards your location, or you are either heading towards an appropriate facility to handle advanced neonatal resuscitation. Because if the heart rate remains below 60 despite adequate ventilations, warming, and chest compressions, then those are indicators for the need of ongoing advanced resuscitation, and you should take steps to deliver or transfer care of the newborn to those higher levels of care as soon as possible. Also, don't forget during this time, the mother is a patient too. And after delivery, as you're doing this care, the placenta is likely going to start to deliver. So the mother may be experiencing postpartum hemorrhage, pain, and contractions. So there's a lot of scene management that has to occur in these scenes. So it's really important to get those resources heading your direction sooner rather than later.
The newborn assessment here can be thought of similar to a secondary assessment that we would perform in a pediatric or adult patient, and can occur at several different points throughout neonatal care. This can occur post delivery in a vigorous newborn that is in the mother's arms and resting comfortably. This can occur in a newborn that is receiving ongoing resuscitative measures. And this can occur within the first 30 days of life, in that neonatal period after a baby has been discharged home from the hospital. And this assessment should start with assessing the newborn's general appearance, looking at their level of activity, their alertness, taking note of their tone, skin color, and respiratory status. So, some signs of respiratory distress in a neonate would include tachypnea, nasal flaring, grunting, retractions, and cyanosis. As you move on from general appearance, it's best to begin with auscultation because it's likely that the neonate is sleeping, as they do a lot of that within the first 30 days of life. So, taking advantage of auscultation while the newborn is quiet helps you get a better assessment of their lung sounds. Newborn lung sounds should be clear and equal bilaterally. If you have lung sounds that are unequal or unilateral, that could signify a pneumothorax, could signify a pleural effusion or a diaphragmatic hernia, all of which are serious conditions that would require uh, prompt transport to the hospital. Once auscultation is complete, perform a head to toe exam. Start by looking at the newborn's skin for any abnormal rashes or lesions. Palpate starting at the head, looking for any asymmetric features. Assess pupillary responses. Look at the position of the ears. Assess the nose and mouth and clear any obstructions. Palpate the neck, clavicles, and chest, assessing for any asymmetry, swelling, or crepitus that could be a result of trauma during delivery or trauma after delivery, such as abuse of a neonate. Palpate the abdomen, should be soft and non tender. Palpate the newborn's hips, legs, and arms, again, looking for any crepitus or deformities indicative of trauma. And lastly, perform a neurological examination. This exam is a more thorough assessment of tone and level of alertness than the initial inspection was. It would also include evaluating for appropriate reflexes present in neonates, such as the sucking reflex or Moro reflex. The Moro reflex is also called the startle reflex, which is where the neonate responds suddenly by extending their arms and legs and opening their hands to some sort of external stimuli, like a loud noise, a quick movement, or some sort of sensation, like changing arms from one provider or caregiver to another.
Suctioning of a newborn with rigid or soft suction catheters is indicated anytime you have secretions or foreign material in the airway that you're unable to clear with a bulb syringe. The golden rule regarding suctioning for pre-hospital providers is to use the lowest amount of negative pressure, the shortest amount of time, and the smallest catheter size needed to effectively suction and clear the airway. Generally, we shouldn't use any type of suction pressure in newborns that's greater than 100 millimeters of mercury. Regarding blow by oxygen, as we discussed, this is used when the neonate's heart rate is greater than 100 and they have adequate breathing effort. So this would be that baby, according to our assessment algorithm, that has labored breathing with a heart rate above 100 may require supplemental O2 depending on where their SpO2 range is at the minutes after birth. You can perform blow by oxygen on a neonate several different ways. Set your oxygen to 5 liters per minute. You can use a nasal cannula beside the infant's face or a simple mask. All you're really trying to do with blow by oxygen is just increase the concentration of oxygen around the newborn's mouth and nose so that when they do take a breath in, they're breathing in a higher concentration of oxygen than just room air 21% oxygen. Airway positioning is also a critical intervention that providers should achieve in newborn care as it allows for the best possible ventilations and really opens the airway up so we can get good equal chest rise and fall in our newborn patients. To achieve the sniffing position, what we're looking for is we're looking to use padding underneath the infant's shoulders to help account for the larger size of their head compared to their body. We know that we've achieved sniffing position when you can see that the bottom of the ear is in line with the sternal notch, the anterior neck space, so right here, is open to the environment, and you have a vertical, or excuse me, and you have a horizontal forehead to chin plane. So you can see that on the screen here with this infant from the forehead to the chin is in a horizontal line. The neck space is open, and with padding under the shoulders, that brings the bottom of the ear more in line with the sternal notch. If there was no padding under the infant's shoulders, what would happen is there would be neck flexion. So the head being so large would actually push it down like this, further closing off the airway. So when providing ventilations to a newborn and a neonate within the first 30 days of life, be positive and assess and take those initial steps to achieve sniffing position. So when providing supplemental oxygen and back valve mask ventilation to a neonate, ensure that you have the appropriate airway positioning by achieving sniffing position. It also should be noted here that oral airways and NPAs are very rarely used in neonatal care and is not something that's within the scope of this lesson. Moving further in to some of the practical indicators and importance of recognizing the need for back valve mask ventilation, we can see here from Hammer et al. In a paper that they published that they noted that for every 30 seconds that a delay in ventilation occurs, the newborn's mortality increases by 16%. And that's significant for us as providers because BVM ventilations are something that we should be very well versed in, not only identifying the need, but also providing that intervention. So we can truly make a difference in the survivability of a preterm newborn or a term newborn with complications just by recognizing the immediate need for back valve mask ventilations. Some of those indications would include an apneic newborn, we note inadequate respiratory effort, or we have a pulse rate below 100. Other signs of respiratory distress in a neonate patient could include irregular breathing, retractions, nasal flaring, and grunting on expiration. In the short video here, you can see that this newborn is having difficulty breathing by grunting respirations on expiration and intercostal muscle retractions.
Good girl.
When initiating BVM ventilations in a neonate, ensure that you have the infant back valve mask size available. Incorporate this into your daily checkoffs and your preparation of your equipment to ensure you have the right equipment when it's needed. The main reason for this is because the infant back valve mask can hold about 250 milliliters of air. A neonate's tidal volume is only about 3 to 6 milliliters per kilogram. So if we were to take a 4 kilogram newborn, that's going to equal to 24 milliliters of tidal volume. So only about 1/10 of the BVM's volume will actually be in use for each breath given to a neonate. Next, obtain an airtight mask seal and ensure the airway is clear of secretions before ventilating. So this would include suctioning with a bulb syringe and then obtaining a mask seal. Now, most of your infant BVMs come with two sizes. They come with a larger size, typically used for infants, and a smaller size that's used for neonates within the first 30 days of life. Regardless of the mask size that is chosen, it should cover the nose and mouth and obtain an airtight seal. So you may have a larger than average neonate that the infant size mask works better than the neonate size. That's acceptable. Ventilate a neonate at about 40 to 60 times per minute. Avoid hyperinflation and overinflation of the chest, as it can lead to an increased risk of barotrauma. Provide only enough tidal volume to see chest rise, and you're going to give about one breath a second. Chest compressions are indicated in neonates whose pulse remains less than 60 beats per minute after they are unresponsive to stimulation and ventilations. 2 people are needed to deliver effective chest compressions and continue BVM ventilations. There's 2 different methods that you can utilize chest compressions. Both are acceptable. The thumb technique versus the 2-finger technique. The thumb technique is, however, the preferred method of providing chest compressions in neonates. Regardless of the method that you use, when providing compressions, compress 1/3 the depth of the chest and ensure that you're allowing complete chest recoil. And as part of a two rescue routine, providing compressions and ventilations, use this cadence at the bottom. 1 and 2 and breathe, and 1 and 2 and breathe, and 1 and 2 and breathe. You would squeeze the bag valve mask on breathe and release on 1. And as a team, the person doing compressions would repeat this cycle continuously throughout the resuscitation so that both providers can remain on cue with compressions and ventilations. So let's put everything that we've recently learned together with a short case study. We're dispatched out to a 25-year-old female for pregnancy complications. On arrival, we find a patient that is having frequent contractions that are 2 minutes apart and feels the need to push. She's 35 weeks pregnant, and we identify this is an imminent delivery. We move the patient to the ambulance, further assess OB considerations such as prenatal care, and prepare for delivery. We prepare a resuscitation zone with the appropriate size neonatal equipment and begin the delivery process. We call for additional units, understanding that we have 2 patients after delivery. Fortunately, the delivery goes smoothly. And what does the first 30 seconds of neonatal resuscitation look like? Exactly. We should be drying, warming, and stimulating the newborn, clearing the airway of any secretions as noted. In this case study, the patient has what looks like meconium in their nose and mouth that you quickly suction with a bulb syringe. After the first 30 seconds passes, you identify that the newborn is not crying vigorously. What are the next steps? It's time to go ahead and clamp and cut the umbilical cord and move this newborn to the resuscitation zone. Be sure that you cut the umbilical cord 4 inches away from the baby on the mother's side and on the infant's side, and use a sterile instrument to cut down the middle. You assess breathing and heart rate and find the heart rate to be 110 beats per minute and the newborn to have labored breathing and gray looking skin. What intervention is now indicated? Absolutely. Bag valve mask ventilations at a rate of 40 to 60 beats per minute, ensuring you have equal chest rise and fall and avoid overventilation and hyperventilation. We perform this intervention for 30 seconds, assessing the newborn's response, and at 1 minute, it's time to assess our APGAR. We look at appearance and we find that the newborn is still looking blue and pale. We identify a pulse of 70. What should we do at this point? Yes, we should immediately discontinue assessing the APGAR score to begin chest compressions. So you and your partner begin chest compressions and ventilations at this cadence. 1 and 2 and breathe, and 1 and 2 and breathe. And you continue this resuscitation for another minute. Now, during this minute, you can still take note of the APGAR score. So if we were to continue it, we would find that the infant has no response or no grimace, is floppy, and weak respirations, giving this newborn a APGAR score of 2 at the 1 minute mark. So we continue our chest compressions and BVM ventilations and start to identify the newborn is crying and moving around more. On reassessment, we now have a heart rate of 120 beats per minute, and we can stop doing CPR and continue assessing the need for BVM ventilations. We identify at this point an APGAR score. The patient has a pink body and blue limbs, a heart rate of 120, cries upon stimulation, resist extension of their legs, and has a vigorous cry, totaling an APGAR score of 8. At this point, we feel comfortable with the vigorous cry and the quality of respirations to stop BVM ventilations. Next, give the newborn to the mother, encourage skin to skin contact with the mother, encourage her to begin to attempt to breastfeed, as that's going to have benefits for both the baby and mom. Don't forget to assess the mother during this point, assessing for hemorrhage, and also counsel her as well, as that's a traumatic experience to see the delay in the transition to extrauterine life. And lastly, ensure that you're keeping the newborn warm, swaddled in blankets, the heat on in the ambulance, and continually assess as you transport to the hospital.